Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. My name is Terry Fletcher. This is episode 43. And for the new listeners, we appreciate you tuning us in and seeing if you like us. We hope you do. For our loyal listeners, we're over 15,600 this week, and we're pretty excited about that. So we do work really hard to bring you a quality product each week, and we're really glad that you've tuned in. One of the things that I just wanted to clarify what the podcast is, actually. The Codecast is a play on words. So as a medical consultant, one of my primary things that I do is I'm a coder, a certified coder. I've got 13 credentials in coding. But I also like to focus on reimbursement. As you know, I'm all about revenue opportunities, billing, because I think billers have such an important role in the coding process, but also compliance, management options. We did a Codecast recently on how to hire an office manager for the billing office and for your medical practice. So we have a lot of different things when it comes to really trying to encompass the whole thing about coding, billing, reimbursement, compliance, management, HIPAA, just all of that. And it really kind of relates to the Codecast because whether it be CPT or ICD-10, which is when we deal with procedural coding versus diagnosis coding, it all intersects and interlinks, and we just have to make sure that we're really on top of some of this information. So today, once we get into the coding information, we have to make sure that from that coding report or from that anything that we're submitting to the insurance company, then we have to get it paid. And when we get those denials, what do we do? And so even though I have done a Codecast back in the beginning of the year, back in February, with regard to collection and appeals, I just want to talk a little bit about some tips for collections today. And then also some consistency within the billing and coding just can really hopefully give you some information and really help you in your collecting process. So it's going to be a little bit shorter today than normal, a little bit informal. I like to call this kind of one of my quick hits. And hopefully when you're listening, you'll find some tidbits that you will find that you can use. But first, we'd like to say thank you to Advanced MD. We're brought to you today by Advanced MD, spotlighting telemedicine as a solution that's proven to boost patient engagement and bring in new revenue streams for your practice. AdvancedMD.com. And Healthcare Executive. Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners, healthcareexecutivesnetwork.org. Okay, so the first thing, I really just want to have a kind of a brief discussion. Somebody asked me recently if you could really give some tips and really tell us just some quick things. If, let's say, we were doing just like a coffee break and we were just saying, I'm struggling in my collection office, Terry, what would you talk about, or what would you tell our staff and our collectors that they could just quickly hear and go away and say, okay, this is what I need to look at when it comes to addressing things that are on our desk? Because let's face it, our desk piles up. And it piles up big, and all of a sudden we've got several things that we need to send in for collections and trying to appeal. And sometimes it gets really tough to do that. So how do we just give them some tidbits so that we know, how to attack your desk? Well, the first thing I would look at is, first of all, and this is one of the big lessons when it comes to collections in the medical practice, give payers what they want. Look at the remarks codes on your explanation of benefits and address those specific edits. So don't hand them back the same medical record. They're just going to deny it again. Address the remarks codes. So missing information and bundled services, they're really a lot of the common reasons for claim denials. Payers often look for additional diagnostic information or an additional op report or an additional lab report or result and won't pay the claim until they receive this documentation. So when you're looking at your explanation of benefits, what you want to look for are those error codes or those denial codes at the bottom of that explanation of benefits, or we call an EOB, or if it's Medicare, EOMB. And when you look at that information, basically address that. So, okay, it's denied because of bundling. So go back and look at your, IntelliCode or Alpha 2 or your CCI edits, and is this actually bundled? Is it something we should have billed? Did we use the right modifier? So address those edits, specific denial codes, and when you look at those, you'll actually be heading in the right direction. You also want to make sure that if you're going to give an appeal letter or cite an appeal letter, that you're giving regulation. There's nothing worse than when I see a practice saying, you need to pay me because you didn't pay me before, or I had a recent practice that didn't like their fee schedule. There was nothing wrong with the claim. They got paid what their contract was, but they said, yeah, they didn't pay us enough, so we went ahead and rebuild it and asked for more money. And I was like, okay, wait. If you signed that contract and you didn't negotiate prior to signing that contract a better rate for yourself, you're kind of stuck with that rate. So those kinds of things should never be in an appeal letter. But let's say that you have a local coverage policy that allows for smoking cessation to be billed with an E&M service on the same date. And that is actually something that is out there, especially for Medicare. And they now, as long as the patient has a smoking-related condition, they will waive the copay and deductible. But let's say that you have a payer that wants to deny it, and it is, let's say it's a Medicare payer or even a commercial plan. You want to cite the regulatory information in the appeal letter. If it's Medicare, you want to look for what we call local coverage determinations, or LCDs, and national coverage determinations as well. And also the Affordable Care Act actually has their own regulations. And then of course you want to use CPT language. One of the things that I deal with quite a bit in orthopedic is how to bill for multiple services. So for example, in your CPT book, if you're doing a shoulder surgery, so let's say you're doing a rotator cuff repair, but you're also doing, let's say, other services with that, so subacromial decompression, and then maybe you're also doing a tenonesis, and so you're doing it arthroscopically. So you're in your CPT book trying to get those paid. Well, the CPT book is pretty clear that on certain services you can use a 51 modifier, not a 59. It actually says a 51 because they're not bundled or they're not inclusive of each other. So basically, when you're using that kind of regulation or information within your appeal letter, now you are the one setting the rules for the payer. You're not the one that's basically saying you're going to pay me based on what you're saying within your contract. You're basically saying you're going to pay me based on what is the language that is a correct coding. So we want to make sure that we are using that regulatory information, citing CPT language, and that's one of the best ways to fight claims. It tells you directly what you can and can't do, and it also basically gives you the language to use within your appeal letter. One of the things that happens quite a bit is when your physician, and I'll just stick with orthopedic, when your physician is doing any kind of shoulder surgery, a lot of times they will do an open shoulder surgery, which means they're actually taking a scalpel and opening the area, but then they'll also do an arthroscopic surgery within that same encounter. And when that happens, it means that they're doing one through the scope and then one open. So a lot of times they will do a mini open rotator cuff repair, but they're also doing let's say an arthroscopic, let's say reverse shoulder. And you can code for each of those, but then you have to make sure you know what kind of modifier goes on that. Same thing with what we were talking about before. So understanding the CPT wording, understanding what they will allow. When I do dermatology coding, okay, in dermatology, we get a lot of denials and a lot of requests for records, because when you're doing your layered closure or you're actually looking at debridements, you have to do, you're doing the width and you're doing times the length. You have to make sure it's measured in centimeters. If you don't measure, including the margins of everything your physician is taking away from that area, then you're not going to get paid directly. And so we really have to make sure that we are understanding some of those, not just regulatory information, but some of those nuances that you can find within the CPT book. One of the biggest things I do too is, I'm just going to go back to orthopedic for a second, because this is one that's hard to get paid. When you do removal of loose bodies, and you're trying to get paid on that, in 29815, it's tough sometimes because if you're in the knee or the shoulder, what the AAOS guidelines say, and that's the American College, and then you're dealing with the Orthopedic Surgery, the association. What that says, it has to be at least 5 centimeters. Well, what you're looking at there is you want to make sure when a physician takes out the loose body of a patient, whether it be the knee or the shoulder, have them put it on the table and then either use the fluoro machine, or there's always a ruler on the table when you're in the OR, and make sure that they just measure it and take a quick photo for you on the fluoroscopy machine. I've had to send photos all the time when I'm doing an appeal. And as long as they can see how big it was and what it looked like, payers love appeals, would have pictures. So make sure you're sending pictures. And you would have a lot more credibility as far as trying to make your case for that. So those are just a couple of things that you can do when you're trying to appeal quickly and being prepared on that process. But also being prepared to bring the patient in the process, into the collection process if necessary. Remember, you're appealing the claim on behalf of the patient who's the actual subscriber. So ask for specific internal criteria on which the payer, is basing a denial. This information goes beyond the reason denial code that we talked about. And, it can also help providers craft an argument to fight the denial and enlist your mid-level providers. A lot of time, the mid-level providers can give you that clinical piece that maybe you don't have as a coder or biller or a collector, and they're usually more open and have a little bit more time to basically approach them with some information. So those are the things that, just off the top of my head that we really want to take a look at when we're doing collections, and some things you can take away from that pretty quick. One of the things that is really helpful, and I find some of these tidbits in actually our next sponsor, Medical Economics. And so just to give them a plug quick, Smarter Business, Better Patient Care, medicaleconomics.com for the business of medicine, digital magazine, and health IT. And one of the things that they actually talk about too is to demand a peer review. So ask the payer to provide the credentials of the reviewer. What this means is that a lot of times you're going to see a nurse case manager on a letter for a denial that is denying something for a general surgery. Well, if a general surgeon is, taking out somebody's colon, plus also dealing with a small colon on that patient and maybe doing a takedown, and then also maybe doing some kind of a spyglass procedure to take a look at the anastomosis of where the connection is from the two intestines, and you've got a nurse reviewer saying that they can't do it for some reason, you need to get a physician involved. And what a peer review is, you need to demand it. They have to do it. It's in every payer contract. It's that a physician in the same specialty with the same credentials reviews the appeal. So when your physician feels that they can make a case for medical necessity, even when the payer doesn't agree, it also buys you some time to find out if your physician actually documented appropriately. So the more specialized the treatment, the more critical a peer review is to the review process. So instead of relying on just that nurse case manager, which is often the case, make sure that you are looking for that peer review, because that's going to make a huge difference when it comes to getting the outcome that you want in that collection process. And I would say the last thing I would look at when it comes to, really making sure that you're understanding the process and how to make it work, file your appeals within 45 to 60 days after you receive the denial. This may go beyond a payer contract or against many consultants, and I know that will tell offices, do 180 days, and I disagree with that. The fresher the claim denial, the better chances you have of it not being archived in the payer system. Now, the one thing that you'll have to do is be very disciplined on this process. If you're a collector or a biller that also does collections, you can get something in the mail from the payers and that'll basically say, we got it. You have a denial, and you'll put it in your stack of to do. You should see my stack of to do. All of a sudden you're saying, okay, it's sitting there. I'll get to it. And 10 days pass, 2 weeks pass, and all of a sudden the clock's ticking. So it's the same thing when we were talking about that breaking news from Medicare, where the doctors need to respond by September 10th. Well, that's less than a month away now. And I started talking about this way back in July. So that's where you have to really be proactive, and understand that it's really important to get that denial, get that collection process started, and make sure that you're just not waiting to get it done, that it's not sitting on your desk for, 3 months or longer, because then that can be a problem. And then at that point, some of the payers tend to archive that information. But you also want to make sure that you've got enough time to talk to the patient about it as well. And make sure that you're starting the process, meaning you're pulling the report, you're pulling the documentation, you're understanding what you're looking at, so that you can have all your ducks in a row before you submit the information. You don't want to be kind of saying, okay, well, you're going to pay me more because I'm looking at this and I don't like what the EOB said. You really want to look at not only regulation, CPT language, code linking it, and if you have it, the payer contract language to fight a claim when you're communicating with the payer. The other thing is make sure you're not sending appeals to the claim PO box where you would submit a claim. There's a different department for this, so that'll get lost in the shuffle and they will not address that issue. So we always want to keep that in mind. What I may do is next week when we talk about this, I'm going to expand this a little bit further. And as I get into some of since we have our top 10 Tuesday the next week, I'm going to actually talk about just some things that have come in on coding and billing and collections as far as questions. And we'll really kind of dig deeper into this, making sure that you're really understanding the collection process. It's just as important as the coding process. The coding is, what is extrapolated from the reports from not just a procedural and ICD-10, so the diagnosis standpoint, but then on the back end as a collector, you also have to understand contracts and payers and really kind of dive into that sector. And so we're really going to focus on that. I've received numerous questions when it comes to collections, and we really want to address that next week. So our final sponsor today in this episode is Keck Medicine of USC. Over 500 nationally renowned physicians at a leading academic medical center, keeping you healthy, on track, and doing things you love. KeckMedicine.org, ranked in the top 50 hospitals in the country by U.S. News and World Report. Also, I know many of you have asked and emailed inquiring about being a sponsor for our podcast. We now are scheduling into October, so thank you for your continued support. You can email me either at terryfletchercpc@aol.com or at terryfletcherccc@gmail.com. Either one works. And so for today, let me get into my coding question really fast so that I don't forget that. So a question came up and it says, can we automatically report a 93320 and a 93325 in conjunction with a 93312? Well, this is for a TEE. So what we're talking about here is when we're looking at a Doppler and color flow when billing it with a service that would be an electrocardiography transesophageal. So we're placing a probe down the patient's esophagus and taking some M-mode image recording, and then also dealing with an interpretation and report. So be careful when you are coding your Doppler and color flow. It's not bundled. It is something you can code extra. They're add-on codes, so they do not need modifiers beyond a 26 modifier if you're in the hospital setting. In the office setting, you would not need a modifier. But these two components require more than just a structural diagnosis. So spectral Doppler is used to assess the speed and movement of the blood through the patient's heart. And so this allows any evaluation of abnormal communications between the left and the right side of the heart, any valvular regurgitation, so leaking of the blood through the valves, or stenosis, which is the narrowing of the valve area. And so the calculation of the cardiac output and ejection fraction on this is done with the Doppler, and it's displayed in the black and white area. Now, on the other hand, Doppler color flow may be added to enhance the image by assigning colors to differentiate the direction of the blood flow. And so you can't always assume that the 93325 is always being used. It has to be documented. So there's reasons for using that, and typically it's valvular disorders. So when I say structural, you're looking at dyspnea, shortness of breath, palpitations, something other than the chest pain and the immediate possible collapsed heart area, if you will. So when you're looking at TEEs, make sure, and also stress echoes, if you're going to add the Doppler and color flow, just make sure it's well documented, and then you can add them both to those services. So thank you again for attending today. We look forward to having you on the next episode of the Codecast podcast. Everybody make it a great day.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.